Okay, so dysphagia is a term to describe a difficulty with eating, drinking and swallowing. So there's lots of causes of dysphagia in children and young people. So today we're generally going to talk about dysphagia in the paediatric population. So first of all, a neurological impairment, obviously caused by lots of different things. Quite typically that's seen in children with cerebral palsy, children with a developmental delay, cardio issues. So because the mechanism of swallowing means that you have to stop breathing, that can, if you're already kind of on quite low oxygen saturations and have cardio difficulties, that can impact on your ability to do that and ability to eat and drink and swallow safely. Respiratory disease, so obviously for some reason we eat and breathe with kind of the same tubes, so yeah, again you have to stop breathing, so it just puts pressure on your respiratory system. And also there's kind of aspiration and things like that that will sensory processing difficulties, so we'll talk as well about sensory behavioural feeding difficulties, and also structural anomalies. So for example, like maxillofacial structural anomalies such as cleft lip and palate, and there's also structural anomalies such as TOF, so tracheoesophageal fistula or atrasia. So that's more of a structural anomaly that might affect the swallowing mechanism, but also is going to have big impacts on your respiratory system. And children can also have all or a combination of all of the things above, basically, so it's nice and complicated. So I'm going to go through basically how a swallow works and teach you basically in the same way that a speech and language therapy student is taught. And we're taught that there's basically kind of 3 main stages to it. Various books and things that you'll read might add in extra stages, but there's sort of main 3 stages that we'll talk about, and this is the general kind of area that we're looking at. So the pre-oral stage is often kind of missed out. You often don't think of it, but basically it's the bit where you get excited about eating, where you anticipate eating. So there's lots and lots of clues at the pre-oral stage that tell you you're about to eat something. So for example, it's 1:10. If you haven't eaten your lunch yet, you're probably looking at the time thinking, oh yeah, I feel a bit hungry, I'm going to have my lunch in a bit. Or if you've just eaten your lunch, you won't really be anticipating eating anything for a while, but you've kind of got in your head like, oh, I'm going to have a snack at 3 o'clock, or I'm going to have my tea at 6 o'clock, that kind of thing. So yeah, kind of anticipating the time for meals, thinking about your favourite foods, being able to smell food that's cooking, see food preparation, so see that food's being cooked, see that table is being laid, and also like gastro signals as well, so the fact that you've got a rumbling stomach, the fact that you feel hungry or you feel thirsty. So all of these things come into the pre-oral stage, and it's really, really important to be kind of prepped and ready and excited to eat, because yeah, you're you have kind of saliva, your stomach starts to produce more acid, it's ready, you're kind of ready to eat. And the pre-oral stage is often impacted on children who have sensory impairments. So if you've got visual impairment, maybe you're not noticing that all the snack food is coming out, or if you've got a hearing impairment, you can't hear the clink of cutlery in the next room that tells you that food is going to be kind of prepared. Children can also have disordered hunger cues as well, so particularly if children have had kind of enteral feeding, so like an NG or a PEG, they might have quite and especially if they've maybe had gastro issues as a child and had to have continuous feeds, they're not used to that kind of rotational feeling hungry and feeding, feeling hungry and feeding. Also children who don't enjoy eating, so when all these cues come that tell you that you're about to have snack or you're about to have a lunchtime, that might not be a nice thing. These children might start to get really, really anxious because they know they're going to be expected to eat something that they don't want to eat. And of course, any kind of eating disorder as well can impact on the pre-oral stage, on you getting ready and excited to eat. And it's also worth thinking about those children who have maybe more severe learning disability and really struggle to think about the like the routine of the day. So, or if there's no visual timetables and that kind of thing, that we go from one thing to the next thing, and all of a sudden there's a load of food in front of them, and they weren't kind of ready yet to eat, or they didn't have all those pre-oral stage cues of them getting ready to eat. Okay, so the next stage is the oral stage, and this is the bit where basically we put the food and drink in our mouth and we chew it and we make a bolus, which is a kind of a really gross word, but it's basically making like a little ball of food that's ready to swallow, essentially. So in the oral stage, we need lots of kind of physical movement of our face. So we need lip closure, we need good jaw movement, tongue movement. So babies just have a forward and back tongue movement, which is that like suckle movement, and then as your motor development matures, you have like side to side rotary movements, and also dissociative movements as well. So your jaw can go in one direction and your tongue can go in a different direction, and so you can eat more challenging things, you know, stuff that mean that you need to sort of fish food out, you know, out of the back of your teeth and that kind of thing. And also saliva production and management, so that you've got enough saliva to break down the food, but also you're not kind of dribbling everywhere. And the aim of the oral stage is to form a bolus of food. Sometimes there's an extra stage of swallowing put in here, which is called the oral propulsion stage or oral transit stage, which is just a bit when you've got that food ready to eat, when you start to move it back in your mouth ready for the swallow. But I'm just going to include all that in the oral stage. And obviously there's lots that can go wrong in the oral stage. So if you've got delayed oral movement, you're going to struggle with more challenging textures, so you might need to stay on kind of softer, more consistent, yes, kind of same consistency foods for longer. You may kind of start to lose food out the front of your mouth if you've got sensory differences. So if you've got autism or cerebral palsy, you might not notice that you're losing food out of your mouth. You might not notice that you've left food, you know, that's gone under your tongue or stuck behind your teeth and things like that. So the next stage is kind of the most complicated one, and it's the pharyngeal stage, and it's the most complex, and it's also an involuntary mechanism. And the aim of this stage is so this is the bit where, for some reason, mammals are designed or evolved to have their food and their air pipes cross over, which is a ridiculous thing, because it means that there is a lot that can go wrong and there's a lot of complicated stuff that needs to happen when you swallow. So basically you're trying to get your food out of this tube to skip over your air tube and go into your food tube. So there's lots and lots of things that are needed to protect the airway and also protect your upper airway as well. There's a bit, you know, it can, if you have poor kind of soft palate, velum closure, then all the food can come out of your nose and things like that. So the pharyngeal stage is the most complicated one. So we're going to watch some videos of video fluoroscopies, because they just explain the pharyngeal stage a bit easier. So the main thing about the pharyngeal stage is that it is complex, that it's involuntary. So it's not, you don't control all of these bits. It's your kind of cranial nerves that are doing that. So of course, if you have a neurological impairment of any kind, that's when it can get impacted. And the main aim of the pharyngeal stage is to protect your airway, to get that food, that bolus, to go into your esophagus and not into your trachea. So let's watch some videos of these. Okay, so first of all, we've just got quite a nice video. Oh, sorry, everyone. Of the normal swallowing process. I'll just wait for these adverts to finish. There we go. Okay, so this is just going to show a normal swallow and a kind of a sagittal view of a bolus being kind of, I think it's food, so it's being chewed and then it's being swallowed. So we'll just quickly go through what happens. Okay, so you can see there, it goes into the pharynx and the esophagus drops and covers up the top of the trachea and the food goes down the esophagus. So this is a slow version of what happens. So the bolus has been made in the mouth in the oral stage, and it moves towards the back of the mouth, which is kind of the oral propulsion stage. And different things happen. So the velum, which is, so there you go, you see it's gone to like the focal arches, which set off all that kind of involuntary stuff to happen. And the involuntary stuff that happens is, so first of all, you can see the soft palate raises. So that bit with your uvula on, that raises up and it kind of seals the back of your nose so that no food can come back out of your nose. Also what happens is that you have a little, can people see where my cursor is indicating? There you go. Can people see it moving around the screen? Not sure because I'm just pointing out various things. So in your larynx you have a really strange bone that's not attached to any other bones. It's called the hyoid bone. You can't really see it very well on this picture, but it's around, oh no, sorry, it's there. And the hyoid bone lifts up and forward, so it basically moves that whole your larynx, which is here, it moves your whole larynx out of the way of the food essentially. So that's the first protective thing that happens. I'm not sure if it really shows up very well on this video, but your larynx is moved up and forward by your hyoid bone. Your vocal folds close, then your false vocal folds close over the top of that, and then your esophagus flips down and covers the top of your trachea. So you've got four things that protect your airway. So you've got the fact that your hyoid bone elevates, moves everything out of the way, secondly, your vocal folds, thirdly, your false vocal folds, and then fourth, it is your esophagus, your epiglottis kind of swings down and covers the top. And at the same time as that, your cricoid sphincter is opened, and it means that all the food is far more likely to go into your esophagus rather than your trachea. So let's watch a little bit more. So you can see there that the soft palate is closed, that the epiglottis is swung down and is covering the top of the larynx, which is the top of your breathing tube, the top of your trachea. Obviously, it doesn't stop here for this long. This is just pausing because of the video. And then I don't know why this is taking so long. Yeah, so there we go. The rest of the bolus goes into the esophagus, and then peristalsis kind of pushes it all the way down your esophagus into your stomach, and then your the cricoid sphincter again kind of closes really, really tight. But obviously when that doesn't happen, you can get kind of reflux and that sort of thing. But there we go. That's the general overview of how a typical swallow works. And now let's watch that on a video fluoroscopy, because these are just really, really cool if anyone's ever seen a video fluoroscopy. Okay, so first of all, we've got a normal swallow, and the esophagus is kind of here. It doesn't really show up particularly well on x-ray because it's like a closed tube most of the time, whereas your trachea shows up because your trachea is like, it's an open tube that's held open by kind of rings of cartilage, and it's open all the time for breathing. But yeah, your esophagus, your food tube, is kind of down the back here, and your trachea is there and it's open all the time, so it needs a lot of protection in the swallowing mechanism to make sure food doesn't go down the wrong way. So I think this happens very, very quickly. So it's just pointing out that the food is going to go down the esophagus, not the trachea. There you go. And that's how quickly that happens. So if we just go again. Ooh, I'll just go through really, really slow. So yeah, that's how quickly it all happens in that split second. Oh, I can't even show it. It's too fast. Oh yeah, far too fast. But anyway, so everything, so the vocal folds are all closed, and the epiglottis is swung down, and everything, and the trachea is completely protected. So you can see the black substance here, which is the barium drink. None of it has gone into the trachea. It's all gone down the esophagus, and that's just having a normal cup of tea. Okay. So you can kind of see the swallow as it happens. Oh, sorry. There we go. You can kind of see that all of this mechanism kind of comes back down again. So in this example, this is an abnormal swallow. You can see that a lot of the drink goes down the trachea, goes down the air tube instead of down the esophagus at the back. So obviously, hopefully you can tell already that is very abnormal. This is your piriform sinus. Nothing should ever go in there. And this person has taken some drink into their mouth, and all their drink has immediately just gone and sat there, which shows you immediately there's something abnormal going on with this swallow. You should be holding that bolus in your mouth. Even if it's drink, you should be able to hold it all in your mouth, and then all in one go it should be swallowed, whereas this is just sort of leaking over the back of this person's tongue, which shows that they have some kind of neurological difficulty, possibly some sensory difficulty, because normally you would be this would be, you know, when you kind of your drink goes down the wrong way and you aspirate and your eyes are streaming and you're coughing and coughing and it's really, really embarrassing. That's normally what would happen, but it's not happening for this person. So let's watch the rest of it. So, and already some of it is starting to kind of leak down. So there you go, you can see they tried to do a swallow. Some of their drink has gone into their esophagus, but loads and loads has leaked right into their trachea, and it's already into their larynx, sorry. So it's all hanging around in their larynx and it's kind of coating their trachea. You can see lots of it is going down their breathing tube. Yeah, and as they keep swallowing, you can see kind of bubbles as they're kind of coughing and gurgling, but absolutely loads is going down their breathing tube and ultimately into their lung, which obviously we don't want to see. And also loads is left here in the piriform sinus, so they have clearly have very poor coughing reflex because it's all just sat there. Okay, this is, and yeah, here we go. We've got another example of someone whose drink is going down their trachea and not their esophagus. Yeah, so then already you should basically never see that be able to happen. It's already gone down to their piriform sinus. That should all stay in their mouth and then very quickly swallowed down, like that first swallow that we saw. Oh, horrible. So if we go back to there, see, they tried to swallow it and a lot of it has gone down the esophagus, but it's quite an inadequate swallow because they carry on. There's loads left here that then all leaks down into their trachea, just sort of pools here.
Oh,
there we go. Ooh, there we go. Okay. And then we've got one last one to watch, which is an example of difficulties at the oral stage. So this is someone who's really, really struggling to keep the food in their mouth, to manipulate the food in their mouth. And you can see as well, they keep sort of having to tip their head back to sort of keep their food there, and they're really struggling to move the I think it's food in this one. They're really struggling to move their food to the back of their mouth. And in fact, I'm not sure if they actually manage it at all. And you can also see this person doesn't have many teeth either, so that might be one of the contributing factors, the fact they're really struggling with the oral stage. Sorry, I made it a bit bigger. Okay, so you can see the food's gone into their mouth and it's all just pooling here behind their front lip and kind of under their tongue. So they're kind of tipping their head back and forth to try and move the food around, but really, really struggling. And you can see they're doing some sort of tongue pumping at the back as well to try and initiate a swallow, but nothing's really happening. So this is someone who's really struggling at that oral stage, and they're basically trying to tip their head back in order to swallow the food, but it's just not happening. Yeah, and basically that just goes on for a horribly long time. It's really unpleasant. Okay, so all right then, so did that make sense to everyone? So you can see there's a sort of three main stages, and it's worth thinking about those stages because they're the ones where you can really think about if something's going wrong. So the preoral stage, quite a lot of the time if a child has a learning disability or a sensory impairment, they're not getting ready to eat. They're not anticipating that they're going to eat. All those signals aren't helping them be ready to have their meal or their snack. The oral stage is when you take the drink or the food into your mouth and you kind of hold it all there, prepare it, get it ready. You know, you chew more challenging textures, you get that bolus ready. And then the pharyngeal stage is where you push it to the back of your mouth, and then there's an involuntary mechanism that swings your larynx forward, your vocal folds, your false vocal folds, your epiglottis, everything covers it up, moves out of the way, pulls the top of your esophagus open, and then you kind of, all your food goes down to your stomach. And there's lots of things that can obviously go wrong at the pharyngeal stage, leading to aspiration, which means that your food or drink goes down the wrong way and it goes down onto your lungs, or even causes choking and coughing and that kind of thing. So everyone has probably experienced aspiration. You know, whenever I go for a swim, there's always a bit where I manage to swallow a mouthful of water and it's really, really unpleasant. I cough everywhere. Or you know, maybe you've had a bit too much to drink and you kind of, I don't know, I do this, I'm lying on my back and I'm really thirsty and I think, I've never been able to do it before, but this time I'll be able to do it. And you try and have a drink when you're lying on your back and it goes all over your face and up your nose and it goes down the wrong way and you're coughing and spluttering everywhere. So everyone's probably had an experience of that happening. So often we can see when a young person is aspirating when food's going down the wrong way, because their eyes are watering, they're probably coughing, they probably change colour. But some children, particularly children with cerebral palsy, can silently aspirate, which is really, really frightening. And the only clue that you're getting that their swallowing mechanism isn't working is that they might start getting chest infections. And just children who are just, for example, a child that I'm thinking of at special school was just always kind of very skinny, always had big bags under his eyes, always looked very poorly, lots of colds, lots of coughs, and then kind of chest infections every now and again. And we took him for a video fluoroscopy, and it turned out you could see enormous drips going down his trachea of the food and drink that he was having. So then he went had enteral feeding instead and just had some tastes of foods, and he was like a different child. He was really podgy, he was really well, he didn't have the bags under his eyes anymore. But so they're the sorts of things that health professionals, and particularly speech and language therapists, will look out for to kind of do the next stages of those assessments, particularly a video fluoroscopy. So that's the pharyngeal stage. And another thing that a speech and language therapist will assess is so often children with dysphagia might be fed by someone else, is looking at the feeder technique to see what strategies, what equipment are being used to help someone to eat and drink more effectively. Okay, so let's find my notes. Okay, I'll send out those videos as well afterwards, because they're quite interesting to watch. So the next thing we're going to talk about is kind of sensory feeding. So I'll find my notes again. There we go. So, yeah, when we're talking about a physical dysphagia, and just to make sure I've got across, there's a difference between a physical dysphagia, so when a child has an actual physical difficulty with manipulating food in their mouth with the swallowing mechanism. That is basically in the NHS, that's what a speech and language therapist is commissioned to assess and offer advice for. And so we assess risk, we try and be as holistic as possible, so think about the child and their culture, we think about their environment, what staff and parents are capable of. A big thing that we do is we modify food consistencies, and there's the what's it called again, International Dysphagia Diet Standardization Initiative, which is the IDDSI, which is coming in the last few years, which is basically trying to standardize a bit more. You might be familiar with phrases like, syrup consistency, honey consistency, custard consistency. And the problem was that everyone used these words but meant completely different things. So now the IDDSI has tried to formalise the different kind of levels of food consistency and also different thicknesses of drinks. So you can modify food consistency, and you can also use thickener to thicken drinks, which most people have probably come across. It can give advice on pacing, positioning, working with children who are non-oral to look at see if they can have tastes, what things are they safe to have orally, and then the rest have through a peg, that kind of thing. And also looking at the equipment that's used for feeding, and that's often where an occupational therapist will get involved. So yeah, just things to look out for in terms of signs of aspiration, that you might have a child who their pharyngeal stage might be inadequate. There might be something going wrong. So that's obviously coughing and choking while they're eating, having a wet or gurgly voice while they're eating. So that suggests that food or drink might be sitting in their larynx, which definitely shouldn't be happening. Excuse me. Eye watering. They might change colour, so they might go all red, they might even start to go a little bit blue. And then long-term chest infections and poor health, that kind of thing. So the consequences of dysphagia are reduced enjoyment of eating and drinking. So it's just not enjoyable anymore, kind of refusing, that kind of thing. Children who so malnutrition, dehydration, urinary tract infections can be quite common because through dehydration, poor general health, and pneumonia and chest infections. Those are sorts of things that we can see. And obviously, unfortunately, some children, it can have such an effect on their chest, they can lead to death as well. the annoying thing about dysphagia and most of healthcare is that nothing is black and white. So kind of when you first see dysphagia training, you're told, oh, you know, aspiration leads to food and drink going into the lungs, causing a chest infection. And actually, it's incredible to find the amount of children and people who are aspirating constantly and are fine and never ever ever have a chest infection. So it's never black and white. We look at lots of different things, and particularly the role of oral health and oral hygiene is becoming a lot more obvious. We generally, things that affect a chest infection, children's likelihood of getting chest infection, pneumonia and respiratory disease is their overall health. Obviously their swallow, so do they have a safe swallow, are they aspirating, and also their oral health. And this is quite common for children who have a completely unsafe swallow, so they're non-oral. The fact that we are constantly eating and drinking all through the day basically cleans our mouth. So it means that bacteria builds up and we swallow it and it's destroyed by our stomach acid. But if a child goes an entire day without eating and drinking anything because they're on a peg feed, the bacteria that can build up in their mouth can become really, really extreme. And obviously they can get kind of infections and all that sort of thing in their mouth. But also if they then aspirate on their own saliva, that's really, really bacteria ridden saliva that's going onto their lungs and also going into their stomach as well, making them ill. So the importance of kind of oral hygiene and things like, oh, what's it called again, BioExtra, and that kind of thing throughout the day is just really important. So all of these different things impact on the likelihood of pneumonia and chest infections. Okay, so now we'll think about sensory behavioural feeding disorders. So this is sort of the other type of eating difficulties that you can have. And a really frustrating thing is that in the NHS there is very, very little, there are very few commissioned services for sensory behavioural feeding disorders, whereas it's not one or the other. Very, very often children with a physical dysphagia will have some element of a sensory feeding disorder, and likewise a child with a sensory feeding disorder may also have some element of dysphagia as well. But unfortunately, in terms of NHS, a child who has mainly a sensory behavioural feeding disorder will not be accepted for a referral, but we can go on to other services that child can be seen by. So yeah, so obviously there is different levels of children being kind of fussy eaters or picky eaters, and you might recognise all this kind of yellow food as being the typical thing that a child finds safe and predictable and will just eat absolutely loads of. Or there's an example here of a child being perfectly happy to eat all of these individual ingredients, and as soon as it looks different and it's kind of in a different format, it's absolutely hideous. They don't want to even like look at it or touch it. Because actually eating is and kind of trying new things is a little bit scary. So we do have, it's in fact a developmental stage, and it's called the neophobic stage, and it's around the age of 1 and after. And basically in evolutionary terms, it's basically the point where a child is able to get up and move around themselves and kind of grab things and put them in their mouth. Obviously it's the babies who were neophobic, so scared of new things, and particularly eating green things, which are more likely to be, you know, for example, if you imagine, you know, Neanderthal babies crawling around, we don't want them to just be shoving any kind of green things into their mouth because it's more likely they'll get poisoned. So the babies who were nervous about trying new foods were the babies that survived and didn't kind of eat anything poisonous. So this is sort of something that's very much programmed into us. So around the age of 1, this is when children become neophobic and they're scared. So neo is new, phobic is scared, like fear. So neophobic is being scared of new things, and it's a normal developmental stage, and all children will go through it. And certain children, the stage lasts longer, and some children get used to trying new things a little bit earlier. But all children will go through normal picky eating because it's just a survival tactic. So normal picky eating, and then we also have Arfid, which is avoidant restricted food intake disorder. So there is a kind of point where the normal picky eating becomes something a lot more severe and can even be diagnosed as Arfid. So people might have come across Arfid. So It's an eating disorder which is kind of similar to anorexia because both conditions involve intense restrictions on the amount of food or types that you eat. But unlike anorexia, people with Arfid aren't worried about their body image, shape or size. So Arfid is basically when it's when a feeding difficulty is severe enough that a child just isn't getting enough calories and isn't getting enough varieties of food, and they're becoming malnourished. So sensory feeding disorder is very common in ASD and ADHD, because those children are far more likely to have sensory processing issues. So, food and different textures taste really horrible, and it'll often become more apparent when a child starts to be weaned onto solid food. You might get children who start to gag on lumps or just want to spit everything out. So that's obviously that is a normal part of development, but children for whom that goes on for a long time can suggest that they have a sensory feeding difficulty. And all of these things can be exacerbated, unfortunately, by certain parenting strategies, and these and obviously it's really important to say that parents, the one thing you can do for your children is to feed them and fatten them up, and that's a really important sort of caring role that a parent has. So there's a lot of anxiety and a lot of emotions around it. So parents can often start to become very anxious around meal times if they're scared about trying to get enough food into their child. Parents can often be very clean, so constantly wiping mouths and wiping hands. So children start to get kind of aversive to mess and things like that. And so having an oral sensory aversion is often tied also with having just general sensory aversion. So kind of messy play is quite a big part of starting to tolerate the sensation of different kinds of textures and that kind of thing. So let's see. So in terms of, I can't remember what else I've got on here. Oh yeah, so here's Arfid. So a few people might have heard of this. When was it? Oh yeah, 2019. You might have heard of that teenager who went blind because he had such a restricted diet because he had Arfid. And the really, really sad thing about this is, kind of as we'll come on to, is that if you've got Arfid, really you need to be monitored by, your healthcare professional. And it doesn't really matter if all you eat is chips and crisps, because you can have a dietitian or a paediatrician or someone just to be monitoring your nutrition status, and you can have kind of various supplements for different things. And the sad thing about this is that the family kind of disengaged and they weren't followed up by medical professionals. So actually he then went on for a few years having missing out entire sort of nutrients in his diet, which is why this, I can't remember what it's called now, but it's when I think it's your optical nerve degenerates basically. So yeah, so really, really sad. So as severe as Arfid is, they're still it doesn't automatically mean that you're going to become malnourished, because actually good management can mean that actually you can have kind of supplements to replace all the things that you're not having. Okay, so thinking about the causes, so often ASD, ADHD, learning disabilities, so sensory processing disorders that can be part of all of these things. You can also have children who've had experienced trauma, so it can be if they've had a choking episode, particularly children with autism who have a choking episodes can then become very, very fixated and fearful around that episode. And then of course parents as well becoming very anxious, and everyone becoming anxious around eating and meal times. A really, really big one is children who were tube fed as babies. So it's really, really fascinating if you look into kind of neonatal feeding. So I'm sure Charlotte Hunter will know loads more than me about this, but the kind of developing your sensory processing system, starts from even before you're born. And when a baby is born, the amount of sensory processing they have to work out is absolutely huge. And for a typical baby, the moment they're born, they have skin-to-skin contact, they can kind of smell their parent, their carers, they have skin-to-skin, they're kept a nice sort of regular temperature, and their main sensory like their main sensory experience is kind of breast or bottle feeding, which is a really close, really often kind of, if they're held very close, it's a very kind of dark, calming, kind of pleasant experience. And then obviously going on to kind of like putting their hands in their mouth, kind of grabbing other things and chewing other things. They have lots and lots of stimulation on their mouth and their face and their lips. Whereas a really, really poorly baby who, for the medical professionals, are just their priority is keep this baby alive and try and look after their health status, all of those things can be disregarded. So actually the baby's first experiences of the world are bright lights, loud sounds, very little kind of pleasant physical contact. Everything is putting cannulas in, putting tubes, kind of moving the baby around quickly, all those sorts of things. And also they miss out on all of those, all that kind of oral stimulation of their face, of their lips and their mouth. And if you miss that, then trying to re-establish that can be really, really difficult. So babies who are tube fed very often go on to have sensory and behavioural feeding disorders. And there's a lot of work being done in neonates to try and get all those early feeding and kind of sensory things happening as early as possible in order to try and prevent those things later on. Okay, so yeah, so the rubbish thing about sensory behavioural feeding disorders is that there's basically no NHS provision. There's tiny, tiny pockets all over the place, but as standard, there is no provision really. So the places to go to are, there is the Birmingham there's the food refusal service, which is based in Birmingham, and also integrated therapy services as well. That's a private company that has speechies, OTs, physios and psychologists, and they also work on them. Unfortunately, these are private companies, so there's all sorts of different kind of price scales, but obviously to have really intensive therapy from them ends up being very, very expensive. So it's not something that's available for a lot of parents unless they have some kind of alternative funding. Okay, but generally things that you can do if a child has a sensory or behavioural feeding disorder, so if they are kind of showing lots of anxiety around meal times, if they're refusing lots of food, a really, really important thing is thinking about the fact that food is so much more than picking up a chip and putting it in your mouth. It's so much more than that. It's an ingrained part of cultures. So, you know, kind of what makes, you know, Italy is the fact that you have this delicious food and that you eat this amazing food in China and all that kind of stuff. It's so much part of your kind of your heritage and your family life and your cultural life. You know, meal times are when people sit around and talk to each other. Yeah, there's so many other things that are included in food. I don't know if anyone's ever heard of Huel, but that kind of that like gunky porridgey stuff. Basically, you can just live on that for the rest of your life. You know, chug it down in front of your computer, never ever have another mealtime ever again, and that's all your nutrition, all your fibre, all your calories you would ever need. But no one ever does that because food is enjoyable, isn't it? And food is social. I found out I was allergic to milk a couple of years ago, and I'm amazed at how it impacts me socially. You know, when people get out cheese and crackers, or if you go around someone's house and they've made like a delicious cheesy pasta, all of those things, I found it a real detriment to my social life that I can't sit and share and join in with these kinds of things, that I have to be a sort of fussy eater. I don't know if anyone else finds that, if they've got any intolerances or allergies. But yeah, food is so much more than just the food that you put in your mouth. So it's about working on all those other parts of food. So the first thing is adults and family just modelling enjoyment of food. So if having everyone sit around the meal table, and if the child doesn't eat a single thing, or if the child is actually nil by mouth, if they're peg fed, they should still sit down at meal times and join in with all those other things that happen. Don't worry about food and mealtime norms. So it's actually a really kind of an unnatural thing that we do, that we sort of set out 3 distinct meal times through the day, and you know, there's certain things you're allowed to eat at breakfast, certain things for lunch, and certain things for dinner in the evening, and certain things we're allowed to eat for snacks. And actually, if you encourage families maybe just to ease off on that expectation, if their child, you know, wants to eat, you know, pasta for breakfast and then eat bits of cereal throughout the day, that kind of thing, and doesn't want to only eat at certain meal times, don't worry at all about that. Just take all pressure off to comply with these sort of eating norms, and just concentrate on eating being a positive thing, having a low pressure approach, and also having the children and young people help with food preparation as well, kind of being involved in it, being around food when the expectation isn't that they're going to eat it. Being involved in preparing food, laying the food out, handing food around to other people. There's so many other ways to engage with food that aren't just being sat in a high chair or sat at a dinner table and food being presented in front of you that you're expected to eat, which can be kind of a really scary thing to do. Okay, so that is the end of of what I had planned. So basically, just to lay out the fact that dysphagia can be a physical dysphagia when you have a difficulty with the pre-oral, oral and pharyngeal stages, and this is an assessment and intervention for this can be delivered by the NHS, so you can refer. So I'm going to send around some links afterwards, but there's just the normal Birmingham community kind of referral email address that you can send a referral to. And then you also have sensory and behavioural feeding disorders, which are far more complicated, and unfortunately not there's very little intervention and assessment that you can get on the NHS, but there are things that we can recommend and places to refer people to, basically. Okay, I'll stop recording there.